bedside and positioned by the patient's legs. The foot brake is activated and Robert will be ready to provide therapy. The therapist directs the robot arm to the brace. The two parts are easily linked up by pressing the robot arm's coupling link onto the brace. The therapist will then push record before performing an individual exercise that is particularly beneficial for this patient. The extent of Robert's pattern of movement is not limited to a set of predefined exercises or directions of movement. When the therapist has demonstrated the exercise, she will press play, and Robert, having copied the exercise, will repeat the movement a suitable number of times. Obviously, it is possible to pause the exercise should the patient need a break. Currently, the therapist must perform such exercises manually by repeating activation of the patient's leg into, for instance, flexion, abduction, or rotation. Having Robert as her assistant, the therapist will instead have time on her hands to carry out other tasks. Such time could, for instance, be spent talking to the patient or carrying out other patient-related work in the wardroom. Moreover, the physical strain on the therapist will be reduced, and thus the risk of work-related muscular pain will be significantly minimized, and all the while, the patient will receive optimal physical training. Studies on intensive care patients have demonstrated that the provision of early mobilization will mean that the patient's physical function will have improved when they leave the intensive care unit. It can be concluded that early mobilization is decisive for the optimization